Hello, everyone. This is Cole from the American Journal of Healthcare Strategy, and I have a special guest today, Director of Ambulatory Operations for Stony Brook Psychiatry, Nicole. Nicole, please introduce yourself.
Hi, my name is Nicole Rodecker. I currently work in the Department of Psychiatry. I've been working for Stony Brook Medicine for the past little over 20 years.
20 years is so long. That is so impressive and a wonderful journey that you've had there. Looking through your resume has been inspiring. We've talked a little bit before, and it is just a really fascinating journey that I think will motivate a lot of people hearing about it. Can you tell me where you started off at Stony Brook those 20 years ago?
So I might be dating myself, but 20 years ago, we had paper records. So I was hired as a temp to help purge and file medical records. And they ended up liking me so much that they wanted to hire me. And I started at Stony Brook Urology, and I stood there for about 4 years. And then while I was there, I was promoted to a secretary because I knew how to. Probably the best class I took in high school was the keyboarding class, and that helped my skills. And I was able to transcribe for two of our doctors that did transcription. So listen to headphones, and then hearing them talk and chew and me type. So.
And during that time, you went and got your bachelor's in business from Stony Brook, right?
Yes. So I actually, when I was actually hired, I had a fascinating administrator I worked with, and she said, if you're going to work with me, you're going to go to school. So I went to school. I applied. I first started at Briarcliff, and Briarcliff was a private school that wasn't ideal. Thankfully, they lost my registration and kind of kicked me out, believe it or not. But thankfully, my GPA was so good, I applied for Stony Brook Business, and I got accepted right away. So I didn't have to go wait to be accepted. I was automatically accepted due to my GPA. So it was actually good luck on my part that I got kicked out of Briarcliff. So
that is very interesting. It's funny how a lot of your career, there are things that might look like a challenge, but have really turned into opportunities for you. And looking at your resume, because after getting that degree, right, you went on to become the senior practice administrator there, right?
So in different departments. So I'll tell you the long history. So after urology, I left the state briefly because I had my child. I wasn't done my degree just yet, and I came back to New York, and I ended up finishing my degree, but I applied to a part-time secretarial position. And when I applied to the position, I was told, after I applied, and I took an Excel test and bombed the test, did good in the interview somehow. But actually, no, I think my previous work ethics were spoke for themselves, because I was applying right across the hall from my previous job. So the administrator walked over to my new boss and said, "You'd be stupid not to hire her." So what they did was they took a file clerk that was a secretary, and made me a coder biller. And I had no experience with coding and billing, but I did it. I winged it, and I learned it. And then I eventually became a CPC after I graduated with my bachelor's.
And you mentioned that you had a child during the time that you were working on completing your bachelor's. You had moved out of state, come back, and you were completing the bachelor's while working and raising a fairly newborn child, right? It wasn't too old at the time.
Yeah, I came back to school. I had about, I think, a year and a half left to do. And I started back in 2008 in OBGYN, and then as a coder biller. And then a year and a half later, I graduated. 2009 to 2010 is when I graduated. I forget what year it was.
How did you manage all that? Because coding and billing is not easy to learn either, right? It's not as easy as many people probably think it is. And it leads to a lot of revenue losses, right? So how did you learn to be good at that, go to school, work, and then raise your child all at the same time? What was some skills that allows you to do that?
And the funny thing is, when you say revenue losses, is it's just like I was able, once I learned it, I had a great mentor. First of all, I had a great mentor that was teaching me, that had patience with me. I picked it up fairly quickly. It's just the way I guess I learned. I just learned fairly quickly. And when I went for my CPC, I kind of went back and I was like, all right, let me look at this bigger picture. Let me own my part of this department, right? So, and I found like a little over $100,000 worth of revenue that we were losing on the postpartum unit. So when patients were delivering but never coming back for their postpartum visit in the ambulatory setting, we weren't billing for that. So I was able to find about about $100,000.
Wow.
So.
Wow. Yeah, that is impressive. I've heard that billing errors account for quite a bit of
Yeah.
quite a bit of that, and that's an incredible example of that. And so you kind of spent most of your career in ambulatory, right? Is there times when you went outside of ambulatory?
Very, very few. When I was in the Department of Surgery, I used to help with trauma a little bit, but not full foot in the door. A little bit on it was more ambulatory, so I did all of the ambulatory stuff. I worked with surgeons who obviously did inpatient and on call and whatnot. The closest thing I did to inpatient was having my babies. That's it. So.
Why did you stay in ambulatory? Some people might not like it. They think it's not as glamorous as the inpatient side, but other people seem to have really found a home there, like yourself. Why did you stay in that ambulatory world?
I think is when I went to OBGYN and I became that coder biller. When I graduated my bachelor's, my administrator at the time believed in me so much, she ended up offering, well, I applied and got the job, but offering me the Bohemia manager position, which she trusted me enough because she was like, you don't have the personality to be like a dictator. You have a leader personality. And at the time, I wouldn't consider myself a leader. I was a manager. You have to learn to be a leader. And that's what I'm currently still doing now. I'm learning to be a leader. But I just kind of stood in the ambulatory space. I just tend to stay in spaces until I feel like I outgrow them, and then I move on. I never became interested in the inpatient unit or inpatient units. The only time I ever regretted not doing something was like back when the urology, one of the doctors I worked with, he was like, you really should be a nurse. I was like, I'm too stupid to be a nurse. I'm like, it's not for me. But I regret it because I really think I would have been a great nurse. I would have loved working in the ED. And I think that's the only time I probably would have worked on the inpatient unit or is through the clinical side of things. Administrative, I'm pretty good with ambulatory.
We're glad that you're not a nurse. There, you're here on the on the podcast. If you were a nurse, not that we have anything against nurses, but that's not our area. So they are very impressive, I'll say. And I attempted nursing school, and I did not do well at some of the prereqs. So
I stopped at the prereqs. I saw the prereqs. I was like, I'm not good at that. So
yeah, they're very challenging. That's for sure. And so you worked your way up really well, and eventually you reach this level where you're at now, where you're the director of operations. Can you tell us about the Department of Psychiatry and how many people are under you, and what's your team look like?
Well, prior to me actually even getting to where I'm at as a director, I had become because remember in OBGYN, I was just a single office manager.
Okay.
And then I went to surgery as a practice manager. So, and then the practice manager, that's where I learned to pick up different specialties and pick up different, the way different specialties work, like vascular and plastic surgery and bariatrics and general surgery. And we had a med spa. So I was overseeing probably about 100 staff members, in total, around like 60 actually probably about 90 clinicians and,
Wow.
in various areas. Once I did that for about 3 years, in the very beginning of COVID, I began my role as a director of operations for psychiatry. And moving from clinical to mental health was world changing.
Yeah.
World changing. So I felt like I wasn't in healthcare anymore because it's just so vastly different. So
So when you started kind of having the leadership role back in OBGYN, that was your first kind of, how many people were you overseeing then?
it was close to, I was doing overseeing clinical, like, I think both administrative and clinical staff, I think about 15 people.
15. And then I mean, that's a lot of people that you went on to next, right?
Yeah.
I mean, you said, how many was that? Like 90 to 100 clinicians?
Yeah. So it was more, I was managing the managers. So I
Yeah.
went from managing, entry level staff and medical assistants and LPNs to managing supervisors and managers and nurse managers in that role. Eventually, I obviously can't manage a nurse doing the clinical stuff, so I would get another nurse leader to oversee that
Right.
piece of it. So I don't want people thinking that I'm like telling a nurse what to do.
It increases in complexity, right? You get more and more people that you're working with, and then now you're working with even a different set, right? And so,
Yeah,
how, were you always throughout your whole career adaptable? Is that something that you have a skill that you think is needed in ambulatory care, is adaptability?
definitely, especially with all the changes that are happening in healthcare. Because look, like I said, 20 years ago, we had paper charts. And then we switched to, when I used to do dictation, then they were talking through a microphone. And then now we're doing EMR, and now it just keeps, there's always changes. There's always these rules to go by. Joint commission when you're in ambulatory offices, if you're managing a hospital suite, a hospital site, it's you just have to go with the flow, with the punches, and there's always something that you have to make sure that you're doing. Right now, I'm glad my institution's really focusing on the metrics and the data. So, and I love data, and that's one thing I want to kind of learn more about because there's so much data, but if you don't know what to do with it, it's useless, right?
It is.
So that's one of the things that I look at a lot in my space. When I went into psychiatry, they didn't have an administrator that had never been over them. Usually, it was one administrator. And psychiatry is such a large department with research and inpatient and grants, and they're a really large research and grant department. So ambulatory was kind of, I guess, neglected. So what they did is they split the administrator in half. So I'm half administrator, and then I have my partner who does the other half. And what she's Yeah, so now I was able to focus on the ambulatory side, and what I found out when I first when I walked in, I found out that all the patients were not getting through. The biggest complaint was patients can't get through. And then we found out that 7,500 patients were calling per month, probably a little bit more than that at the time, trying to get to a doctor, but they just kept getting voicemails all the time. So I had to put a call center system in order for the patients to get through. So there was a live answering service. So when you call, you just wait and you'll get somebody on to call, to answer the phone.
So let's pretend just for a minute, and I don't think I sent you any of these questions. So I appreciate you letting me go off script a little bit here. um, let's pretend that I'm at a hospital, and our maybe a smaller institution, and our psychiatry department is overrun with these calls, and it's going to voicemail. What advice are you giving me to get this done? Right, because I wouldn't know the first thing on how to establish a live call line, center, any of this stuff, right? So, and how did you know how to do that too?
It's probably because I did it a lot of times in surgery. So in OBGYN, we already had the call center set up. So, now that they're changing the verbiage to contact center, because that's the first point of contact when you call the office. So I knew how to do it. I set it up for multiple specialties on the surgery side. So I knew exactly, and I think that was the benefit of having years at Stony Brook, because I knew the system. I knew who to contact. I knew who the players were. So if I was somebody new coming from outside, it would probably took them a little bit longer. It got me 2 months to get the system up and running.
Wow.
So, and it was yeah. So patients just kept calling and leaving voicemails. They would leave like 65 voicemails within like 2 hours. So I knew the volume was a lot. I was like, that was my number one goal, was to get that up and running so I could figure out how many phone calls we're getting, and then we're going to split it out, get more staff, and then just be more efficient.
And so you just hire more, call center reps, you find space for them, get the IT to give them the phone
Yeah.
connection. I mean, that must have been a large undertaking. I mean, 2 months, is a short period of time. I want to ask you about work-life balance in your role. Are you finding that you're working during times like this 60, 80 hours a week, or are you still maintaining your work-life balance during that time?
It's funny, pre psychiatry, I would say my work life balance was non-existent. I used to just work and emails all night and whatnot. Psychiatry is all about mental health. So even for us and even for our administrators, even for our doctors. So I've kind of taken a few of their hints and try not to look at emails on weekends unless I want to. If I want to, then fine. It's fun for me sometimes. So, but I've been better with it. So I would say I'm just about like around 42, 43 hours. So
Oh, that's pretty good, especially, I mean, considering, right, during this time,
yeah.
you got your MHA.
Oh, MBA.
You got your MBA. Oh my goodness. Okay.
Yeah,
I'll have
MBA.
to
And then I was with
yeah.
3 kids.
Yeah. So that's what I'm wondering is how did you do that?
Oh, I don't know. I think I definitely needed psychiatry after that. So I started in 2018 when I was still in surgery. I didn't realize if you went to a private school that you didn't know you didn't need to get to do the GRE or GMAT. And that's what was stopping me. It was like, oh, I can't study for these tests. These tests are too much, whatever. And then my administrator at the time was like, just go to a private school, go to St. Joseph's. I was like, oh. And then as soon as they had an open house, I was there. I got accepted and I started right away. It didn't matter that my wedding was during that fall. It didn't matter that I still had a 1-year-old daughter. It didn't matter that I had a small toddler at home. It was just, I was like, when I want to go for something, I just go for it. And then I think about the consequences later. I probably should have thought about it a little bit longer, but I wanted to get it done while my kids were small. So now I graduated in 2022, big load off my shoulders. And can you believe it or not, I'm actually thinking about going back to school again.
That's
It's just,
wild.
I don't know why, but I don't know if it's a mental illness, but
What is your choice this time that you're thinking you're considering?
I was thinking about MHA.
Okay, really? Okay.
Yeah,
Interesting.
yeah, because policies and laws and changes, and then also maybe accounting.
Wow. Very interesting. Yeah. I like both of those ideas. I'm doing the MBA and then the MPH, similar logic there, trying to get the other side of things with policy. But that accounting is also very fascinating. I love one of the things I love about interacting with people is there's so many different paths that people take, and they're all so unique. And so I appreciate you sharing all of it with us. Now that you've been in this role, you mentioned earlier that there are changes, there are things that are changing in healthcare, especially in ambulatory care.
Mhm.
What do you mean by that? What is going on? What changes are you seeing?
So they changed the names over the years. So if like for big systems, we have to follow like meaningful use or now we're ACO or a CIN, and then we have to make sure we're meeting certain metrics. So if we have to make sure we're screening and following through with the depression screenings or following through with breast cancer and colorectal screenings. So as a system. So if we get a referral, we want to make sure that we're calling that referral and making sure we're reaching out to them. So besides that, the institution has goals. So the institution is implementing goals for each department. So we can make sure that we're being as efficient and making sure we have access. And as I said before, like with psychiatry, there's like I don't think I even said this before. Psychiatry has a big access issue. So we have 7,500 phone calls calling per month, and about 2,000 of them are new patient visits. I can't handle
Wow.
2,000 patient visits per month, and that it's a national mental health crisis out there right now.
How many call center staff are you employing? I'm trying to do the math on that. I mean, if you had, you have to be making 250 answers per day for, for that stuff. That's a lot.
Yeah, so right now I have the way I split it up is I have a new patient call center, so they people that deal with the new patient calls. And then I have the regular call center that deals with the follow up, medication management, and whatnot. I don't have nurses, so usually those would when I go to a nurse, we don't have nurses, so we have the staff take messages and we send the messages to the doctor. With the new patient coordinators, what we have to do is we have to field them out. So what we were doing is we had to focus only on Stony Brook patients right now. So we at first, actually right after COVID, we were taking everybody, we were taking every single phone call. Then we were booking out 9 months. That's not
Wow.
doing anybody help, because when people are calling for help for mental health care, they need it now, not 9 months from now.
Right.
So we had to make a decision and just say, all right, we're gonna focus on the Stony Brook patients. Now that we had over 1,000 patient wait lists, and we were able to dwindle it down to nothing for medication management. So now
Okay.
we're able to take on more referrals, which is great. Individual therapy, there's just not enough therapists out there. The government really needs to kind of step in and offer free schooling, or pay for schooling, or do something to get people wanting to go into the mental health field.
So when you say, and this is great advice because so many organizations are struggling with this exact problem right now, right? I mean, as you know, it's it's a worldwide issue, right? So
Worldwide.
you say, we're going to focus on Stony Brook patients. And what that means is people who are already attributed to Stony Brook is that's where they get their primary care from.
Yes. And then what ended up happening is that now that we went through our wait list, when patients call us, um, we ask patients if they have a primary care doctor, because what's most important to prevent things, right? It's to have a primary care doctor so we can make sure we're getting checked up on. So we now ask patients, do you have a primary care doctor? If they don't have a primary care doctor, we work with our family medicine department, and we refer patients over to family medicine so they could get a primary care doctor. Once they're established with their primary care doctor, they go into our integration program to get the mental health services that they need. We need to work as a team, and then this is like, it's collaborative. It has many names, collaborative care, but we have an integration model where we refer patients to primary care. They refer patients to us. We get referrals from all departments, but we're trying to get these community callers that don't have a primary care doctor into Stony Brook, get them established, get them healthy, and then get them mental health care as well.
What are we looking at now for Stony Brook attributed patients in terms of wait times? Has that gone down?
So with medication management, it has definitely gone down. For individual therapy, we cannot offer it to anybody. So what we're doing is we're making the main mode of treatment is group therapies. So we have a wide variety of group therapies depending on what the diagnosis is.
So when you say you can't offer it to anybody, does that mean you can't offer it to new people, or there's simply not enough therapists to do any individual therapy?
So basically, I have about a 450 patient wait list on
Okay.
my individual therapy wait list. And the reason why is there's a lot of, you could get therapy within a few days if you wanted to, if you wanted to pay out of pocket. But
Right.
these are patients that are wanting to use their insurance, which rightfully so. Who can afford $800 a month, $200 a visit or less? So it's a very, that's why I said we're in a mental health crisis where the government needs to kind of step in and do something about it.
Now, is that 400 Stony Brook attributed only, or is
Stony Brook patients that have been referred to us, or our patients that have seen the medication management clinician, and they're referred over for individual therapy, and then they're waiting. So we're trying to figure something out, but we're working on it. So
Oh yeah, well that's what I want to say is that you're dealing with these high volumes where it's almost like if something goes wrong, there's going to be a backup even further, right? So your staff must operate as a well-oiled kind of machine. I want to ask why your staff operates so well, why you've had such success. Are there any things in leadership that you are doing that other leaders should work on adopting as well to make their work environment good?
well, I think every ambulatory clinic should have a clinical leader, because obviously I can't do everything myself, and I work with a fabulous leadership team that we have the child, we have adult, we have geriatrics, we have our student training program, which is a self-pay clinic. which has low fees. It's like, really, really low fees. It's between, I think, 60, no, I lied, 20 and $65, I think, at the moment. We'll be increasing it just a little bit shortly. But I think the most important thing is to have a teamwork based environment, have a clinical leadership, and have, buy-in from your leader, from your chairman, from, anybody that's, if you want to make changes, and you have to kind of think outside the box. So one of my examples is this, what we call it is the reverse integration program. I want to help the community callers because I didn't want to just send them away. I wanted to give them an option. So we give them an option of like, do you want to become a Stony Brook patient by, having your primary care doctor here? And then we turn them to Stony Brook patients. We feed the system. We get them patients healthy. And then, we get them mental health services.
So I want to ask another question. This will be my last one for you. You've been giving such awesome answers. I really appreciate it. You talked about in the resume how you rebuilt relationships with OB referrers.
Yeah.
When you have such a long wait list or you're not able to accept services, of course that might damage the relationships. But now you're, of course, doing better. We're getting more, volume coming in. Are there any tips you have for that? For repairing relationships or strengthening or building new relationships with the community and people in the community from your department standpoint?
So in psychiatry, we are like at the opposite level. We're like, we don't want to be seen. We don't have any, don't see us right now, right? Because we have too many patients. But for, the OB and surgery side, take care of your referrals, make sure that the patient, the doctors that are referring patients to you, they get their patients in quickly. You make sure you get the notes back to them quickly. You make sure you get the letters out. You make sure you just communicate with them. Keep in contact with them like once a month or every other week just to say, how's everything going? In surgery, we used to have an RN that did lunch and learns. So about vascular. So I think that's important too. And I think, and we did that with other specialties as well. So I think just keeping that line of communication open. So if there is an issue with the referral process, they know who to go to. They can talk to somebody. They don't have to say, all right, who in Stony Brook am I calling? They're like, no, I'm going to call Nicole because she could take care of it. So.
Excellent advice. Thank you so much for coming on and buying out time out of your busy day with your children there. I know you have many things going on, so I do really appreciate it, and just awesome advice. I think that's going to be really useful for people who are in similar situations. And as you know, there's a lot of us in similar situations, especially in the psychiatry space.
Yes. And anybody that's in the psychiatry space, please reach out to me on LinkedIn. I'll be happy to brainstorm ideas with you guys. So.